Okay, hello everyone. This is going to be the first episode of Usmle in under 10 minutes. I'm going to try to cover as many topics as I can in a quick amount of time. I have the notes attached in the description, and today's topic is going to be acute pancreatitis. I hope you guys like the video, and let's get started. So to begin with, there's two main causes of pancreatitis that you should remember. These two main causes include gallstones and alcohol. Alcohol is directly toxic to the cells of the pancreas, and therefore it causes direct injury leading to pancreatitis. On the other hand, gallstones obstruct the pancreatic duct, leading to activation of the enzymes behind the obstruction, which then destroy the pancreas. We'll talk more about the pathophysiology a little later, but these are the two main causes that you should remember. And I drew this picture down here. You should remember that the common bile duct is part of the biliary system, and it joins with the pancreatic duct to empty into the ampulla levator. So if there's a gallstone that's obstructing these ducts, it can also obstruct the pancreatic duct, leading to a backup of enzymes over here. And this can lead to their activation and therefore autodigestion of the pancreas. Other less common causes that I think you should remember include idiopathic reasons, trauma, steroids, mumps, autoimmune diseases, scorpions, and especially try to remember hypercalcemia and hypertriglyceridemia. ERCP, which is a GI procedure, can also cause pancreatitis due to direct damage or trauma, and drugs like sulfa drugs, anti-HIV medications like didanosine and valproic acid. Okay, next to talk about the pathophysiology, we talked about alcohol and drugs and ERCP. These cause direct injury. When there's direct injury, you injure the acinar cells of the pancreas, which leads to the release and activation of enzymes, which leads to autodigestion. In the case of obstruction, like I said, the enzymes get trapped behind the obstruction, which leads to their activation. So trypsinogen is the main enzyme responsible. Trypsinogen gets cleaved to trypsin, and trypsin activates all the other pancreatic enzymes like lipase, phospholipase, and all those. After these enzymes are activated, there's autodigestion of the pancreas, there's a release of inflammatory cytokines and like interleukins, and this leads to recruitment of inflammatory cells like neutrophils and macrophages, and this eventually leads to the pancreatitis. So presentation, anytime there's inflammation, the patient is going to be in pain. In acute pancreatitis, the pain is an epigastric pain radiating to the back. So remember that because they always mention that in the question stems, epigastric pain radiating to the back. Other symptoms include hypotension and tachycardia. So why do we develop hypotension and tachycardia in acute pancreatitis? That's because of a phenomenon known as third spacing. So these, while inflammation is going on, these interleukins and cytokines, they increase the vasodilation of blood vessels, and this increases the hydrostatic pressure, which leads to capillary leakage. This causes the fluid to shift from the intravascular to the interstitial space, decreasing the effective circulating volume. When you decrease the effective circulating volume, you have hypotension, and as a response to the hypotension, we have a tachycardia, a compensatory tachycardia, and this increases the heart rate or tachycardia. So yeah, this is the phenomenon of third spacing. Third spacing is the movement of fluid from the intravascular space into the interstitial space. And finally, often tested, tetany. We get tetany in acute pancreatitis because as we have breakdown of the peripancreatic fat after the activation of the enzymes, the free triglycerides are exposed, and these free triglycerides can bind to calcium, and this causes hypocalcemia. It decreases the free levels of calcium. This is also known as saponification and occurs due to the fat necrosis in pancreas. So they like to test you on the fact of saponification and tetany and why that occurs in pancreatitis. Here are two physical exam findings that you can see. Cullen sign is edema and bruising in the subcutaneous fatty tissue around the periumbilicus. On the other hand, Gray-Turner sign is a bruising of the flanks. So these signs, especially Gray-Turner sign, is an indication that the pancreatitis is very severe, and it's progressed to maybe necrotizing pancreatitis, which we'll talk about later. Okay, finally, guys, when making the diagnosis for step 1 purposes, you have to fulfill 2 out of 3 criteria. These criteria include acute epigastric pain radiating to the back, so remember that. Elevation of amylase and lipase 3 times the upper limit. So lipase is more specific than amylase because amylase is also found in the salivary glands. So when we look at these enzymes, lipase is a better enzyme to look at to think about acute pancreatitis. And finally, last of all, characteristic imaging findings can also be used. So 2 out of these 3. So complications, the one that's most tested is pancreatic pseudocyst. We'll talk about that on the next slide. Pancreatic abscess, pancreatic necrosis. You should suspect necrosis when a patient has persistent leukocytosis and fever, and the pain isn't getting better. You've given him IV fluid and all that, and nothing. He's just not getting better. That's when you start to suspect pancreatic necrosis, or you might have to get surgery involved. Hypocalcemia, we already talked about. Pleural effusion, left-sided, because some enzymes can escape from the pancreas to the left lung base, causing pleural effusion over there, destruction of the pleura. And of course, ARDS, if the lung damage becomes extensive, patient starts to have trouble breathing, the O2 saturation drops, and that's when you start to think of ARDS as well, and that's tested often as well. So I would remember pancreatic pseudocyst and ARDS. So what is a pseudocyst? So if you remember, normal cysts are lined by epithelial cells. So what they want you to know is that in case of a pseudocyst, the lining is actually not epithelial cells, it's actually granulation and fibrous tissue. To take this another step further, they like to give you a case of pancreatitis, and they give you a pseudocyst, and they like to ask, what is the most likely type of collagen to be found in the pseudocyst? And the answer is type 3 collagen, because granulation tissue is composed of type 3 collagen. So that's how they like to integrate all this stuff. And just as a general knowledge type of thing, pancreatic pseudocysts are very rare in real life. It's more of an exam question, because usually the fluid that accumulates due to acute pancreatitis is reabsorbed very quickly, and we only develop pseudocyst when it stays like greater than 6 weeks. And finally, on the last slide, I have a high yield slide. So, like I said, there's many causes of acute pancreatitis, and they'll ask you what is the most likely cause. So some of these clues can help you differentiate what the cause is. For example, if the AST is greater than the ALT in a 2-to-1 ratio, the cause is probably going to be alcohol. If the MCV is greater than 100, it's probably alcohol, because alcohol causes folate deficiency, and folate deficiency causes the macrocytic anemia. If there's jaundice, bilirubin's elevated, you got to think of gallstone pancreatitis. If the patient had a recent surgery, that's ERCP. If a patient is receiving treatment for acne, think about hypertriglyceridemia, because that's a known side effect of isotretinoin, and isotretinoin is used to treat acne. So remember all these integrative things. And of course, anti-HIV medication, didanosine, which is tested very often, can cause pancreatitis. So on the bottom, I mentioned patient with acute pancreatitis develops dropping O2 levels. You got to think of ARDS. A patient with hyperparathyroidism develops acute pancreatitis. The cause is most likely to be hypercalcemia. Remember, hypercalcemia and hypertriglyceridemia are some of the causes other than gallstones and alcohol that you should remember. Fat necrosis causes saponification, causes hypocalcemia, which causes tetany. That's high yield. Pseudoabscess is lined by granulation tissue, which is made of type 3 collagen. Lipase is more specific than amylase in diagnosis of acute pancreatitis. And finally, I told you to remember that chest pain or epigastric pain radiating to the back is pancreatitis, while aortic dissection also can present with a similar pain. But the difference is that in aortic dissection, we're going to have other signs that are available as well. For example, the blood pressure in both arms will be different. The patient will be much more hypertensive. Patient will have history of like hypertension and all that. So just keep that in mind. Thank you, guys.